Hi, good evening, everybody. We are at 7:30, so we're going to kick off with our webinar for this evening. Welcome to our March Open Hand Therapy Initiative webinar. It is brought to you in association with the University of the Witwatersrand and the South African Society of Hand Therapists. This evening, we've got a presentation on casting motion to mobilise stiffness. We're very excited to have our guest speaker, Johanna, with us. Thank you so much for joining us. I will introduce you now. So when you're stuck with a stiff hand getting started, it really is just an introduction. We're dipping our toes in this evening. So hopefully by the end of this evening, you'll know enough to have more questions and to look up some further training. But in 1 hour, we can't cover all of it. But we'll have a time for some questions at the end. Just a reminder to please utilize the chat box when asking your questions. Our contact details are on the screen, but it is time for us to kick off. So I'm going to stop sharing my screen. And then Johanna, while I introduce you, you're welcome to share your screen. So Johanna Jacobson-Petrov is an occupational therapist from Bulgaria. We're so excited to have international guest speakers. And she's an expert hand therapy clinician with over 25 years of experience working within hand therapy both in the United States and in Bulgaria. She has extensively contributed to the establishment and development of hand therapy within Bulgaria through education of local surgeons and therapists. She undertook translation and cultural adaptation of the DASH outcome measure for Bulgaria, which to date is the first and only Bulgarian upper limb extremity outcome measure. We've had many requests through our webinar for casting motion to mobilise stiffness, or CMMS, of which I was one of the people who wanted the topic, because as a therapist a few years ago working in rural context, came across the concept and didn't have the training and have come across just how helpful this particular modality is. So I'm excited for this evening. So we reached out to Judy Coltage, which is the veteran hand therapy who developed this technique, and she referred us to Johanna. And Johanna is part of a small team that has developed a traveling CMMS course for the American Society of Hand Therapists. So we feel very privileged to have you here with us this evening. She runs a hand therapy practice in Sofia, Bulgaria, and has generously agreed to share her time and expertise with us. So without further ado, I am going to hand over to you.
Okay. Thank you so much for this opportunity. It's really a pleasure to be presenting at the Open Hand webinar series. So my task today is to introduce everyone to the concept of casting motion to mobilize stiffness. And the short form for this technique is called CMMS, or CMMS. So I am based in Bulgaria. I grew up in Canada and I did my OT training in Canada, and then I went to the States and did my CHT. And then Bulgaria was just one of those kind of unexpected life journeys that one goes on without expecting it. And after quite a few years of trying to find someone to do my hand therapy with, like another surgeon who knew what hand therapy was, I was lucky enough to find one. And from there, we just kind of developed our practice. And through the last kind of 20 years, have been working on improving the level of hand surgery and hand therapy. And I'm lucky enough already to have Bulgarian colleagues who are really good hand therapists. So really pleased about that. My personal journey with CMMS started with Judy Kolditz. I'm really lucky to have had her as my mentor. I have huge appreciation and admiration for her knowledge, and she was, of course, the developer of this technique. She was really generous with her time, I must say, because when I first started working in Bulgaria, I still see a lot of stiff hands, but back then I saw really a lot of stiff hands, and it felt quite overwhelming. And so she was really generous enough to get on Skype with me, if anyone understands what Skype is. I'm dating myself, but we would get on Skype and she would just, talk me through what I should be doing with these patients. And I was lucky also enough to go to one of her live education courses. So, and a couple of years ago, she asked five of us to get together and kind of carry on the Sims mantle because she was planning on retiring. So this group of us created a 1-day and a 2-day hands-on ASHT, the American Association of Hand Therapy course. That is taught in the States, and I teach this outside of the States. And we also do at different congresses. We do these 2 to 4 hour instructional courses. So anyone who's interested in this can look out for these. So course objectives, you guys can just read them over, but my main goal for this is really just to introduce you to the concepts of Sims. It's really not like an entry-level kind of technique. It really does require hands-on training. So in an hour, I'm hoping just to kind of introduce you to the topic, get you thinking about different concepts related to Sims, and just kind of spark your interest in this technique. So what is Sims and how does it work? I like to think of Sims as it's used for the I wish you would come earlier stage. You get these patients that come into your clinic and it feels really quite overwhelming when you see a hand like this, which is truly fibrotic. It's got no motion. She's got, this fibrotic tissue all over her hand and her digits. And functionally, she's without a hand, basically. So you feel quite a lot of pressure to help these patients. So Sims is a therapy technique that's used to reduce fibrotic edema, elongate fibrotic tissue, and most of all, correct maladaptive movement patterns. So when you identify a patient that has a maladaptive movement pattern, you apply a plaster cast. So here's an example of a plaster cast, which immobilizes the most mobile joints. So it mobilizes the wrist for sure, and some part of the digits, depending on what the purpose of your cast is. And when you immobilize these most mobile joints, all the active force of the digits is directed toward the stiff joints. And the most important thing of all that I think anyways is the most important benefit of this is that it retrains the digital grasp pattern at the motor cortex level. And as you can see down here, for example, you may use 3 different types of casts for one patient. So getting the rehabilitating the digital motion may or may not be done just with one cast. So that's another thing to keep in mind. So what about the Sims process? So the first thing you have to do is identify the appropriate patient. And well, what's an appropriate patient? It's one with the presence of a persistent maladaptive movement pattern. So if you observe the grasp pattern, for example, in this patient, you can see that this is an obviously not a normal grasp pattern. They're flexing at their wrists and they're flexing mainly at their MCPs. They don't have any IP flexion. And this would be considered the dominant interossei movement pattern. And then the next common movement pattern is this one where they're, again, moving only from the IPs and not moving from the MCPs, and again, moving a lot from their wrists. And that's called the dominant extrinsic movement pattern. So you analyze the movement, and then you decide based on the movement pattern that you see, you decide on what cast design you're going to choose. And there are 6 different cast designs to choose from. And again, unfortunately, because this is only a short presentation, I can't go into the reasons or you would choose a cast design or how you would choose a specific cast design, but I'll do more of a kind of overview. But for anyone who is really interested in this and wants to know, really right away what to do, there's in the Brace Lab website, you can go to all of Judy's videos, and her published work is there for downloading for free. So when you've decided what cast to put on this hand, how long do they wear the cast? That's a really common question I get. And well, the duration, of course, of the wear of this cast is patient dependent. Um, it can be anywhere from 10 days to 4 to 6 weeks. It can be even less than 10 days if you have a patient who's like, you've put a cast on, they're like, get this off me right now. Will you take the cast off? So, but generally like 10 days to 4 to 6 weeks. And the patient is seen consistently throughout the time that they're wearing the cast. You don't just put a cast on them and then let them go out the door. They're seen weekly or even biweekly for cast adjustments and for progression of their exercise program. And just as a quick example, this is a patient that I saw. She had had a distal radius fracture, and she arrived 12 weeks after her distal radius fracture. She was very stiff. And so I decided to do SIMS with her, and I applied a cast that immobilized her wrist and immobilized her MCPs and had her just move her IPs. And she wore this cast for 3.5 weeks. So she wore it for a good long time, and her motion was pretty good at the end. Well, SIMS does not stop when you take off the cast, because after this, you have to do the bivalve stage. So the SIMS bivalve stage requires you to cut open the cast and make it into like a splint cast, so a cast that can be removed. And so you choose to do this once the abnormal movement pattern has been corrected. Okay, so after you see that movement pattern is corrected and you're happy with with the level they've gotten to, you open the cast, you cut it in half, and you put straps on so that they can take it off and put it back on. And so this bivalve cast should be worn continuously initially, and then over time it's weaned. And you really have to be careful in this weaning time frame, because if the bivalve cast is weaned too quickly, or the patient does not follow your directions. So this is her motion within the bivalve cast, and I had given her instructions to wear the cast continuously. Actually, not continuously. I think I told her to wear it for like let's say 80% of the day. She could take it off for hygiene and for doing her other exercises. But what happened was she went on vacation, and 2 weeks later she came back, and this was her motion. So if the patient does not follow the bivalving instructions, you can totally lose the gains that you had achieved in the cast. So the bivalve process is really an important part of this technique. And so let's just talk a little bit about the scientific rationale behind this. So it really has to do with tissue injury and repair. So we all know that the tissue healing phases dictate the biology and the timeline of scar formation. So the inflammatory phase, the proliferation phase, and the remodeling phases are the 3 phases of tissue healing. And the scar tissue that develops during these phases must remodel to fit the function of either the tendon, ligament, muscle, or whatever tissue it's replacing. And how does that happen? Well, the therapeutic force that we provide in therapy stimulates these biochemical and biophysical signals that remodel the tissue appropriately. And we call this therapeutic exercise, it's called controlled stress. And this means the therapeutic force is applied at the appropriate time. So it's applied at one of these 3 points of the tissue healing phases. And it's applied for the appropriate duration of time. Again, if the appropriate time or duration is not correct, then you'll get quite a stiff hand. And SIMS is one example of this controlled stress application. And so what is a stiff hand? The stiff hand is persistent stiffness that occurs in the absence of appropriate or timely therapeutic force. So you have a very fibrotic stiff hand. You have a hand like this. There's clearly a loss of tissue glide, a loss of tissue elasticity. The patient obviously cannot move easily, and he moves the most easily and mobile joints. So his motion is going to be through the joints that are easily mobile. In this case, the patient is moving mostly through the MPs, a little bit through the IPs. And generally, this abnormal movement that you see from a stiff hand, this is non-physiological movement. It's not normal movement. And this abnormal movement pattern then gets reinforced because it's repeated hourly and daily, and it becomes ingrained in the pathway in the central nervous system. And so you may have had these patients that come into your clinic, and you do make progress with them during the clinic, during the therapy session, but this progress, it just disappears the next time they come in. And the patient will tell you that the next day their hand is completely stiff again. And this is obviously due to the brain's preference to move in the easiest way. I mean, our body is built to move in the easiest way, and the easiest way is through the most mobile joints. So you can say that tissue stiffness creates cortical changes. You get tissue tightness, and synergistic motion is lost. The patient is unable to break the cycle of this maladaptive movement, and it continues. This motion is then ingrained in the sensory motor cortex, so that normal motion that the patient had is actually altered to become the abnormal motion within the central cortex. And then that patient adapts that normal movement pattern, that maladaptive movement pattern, as a normal pattern. And so for effective treatment of the stiff hand, the therapist really has to correct the cortical representation. And how is this done? You have to stop the abnormal movement pattern. You have to reinforce the corrected movement patterns. And you have to have this repeated over a prolonged period of time, because we all know that any change that happens at the central cortex takes quite a long time to happen. I put this article in just as a reference. It's an open access article, and it's out of the group from Sweden that is talking about neuroplasticity and what the implications are for us as hand therapists. And I would even say that, especially in ortho, where we may not be so familiar with the neural side of things, this is actually really important and has really important implications for what we do in our hand therapy in the ortho field. So so what makes SIMS useful? SIMS addresses multiple issues concurrently. Within a SIMS cast, you're making the patient repeat the corrected active motion. So they're using active motion, and they're repeating this corrected active motion over and over and over again. So because they're repeating this motion, this corrected motion, this addresses the poor CNS patterning. Also, the motion of the skin within the cast, it just gets softened by that kind of micro motion within the cast. It really does become soft. That kind of brawny tissue that happens in the palm becomes more mobile, and I'll show you a picture of that later on. And the force, the force that you're using, the active force or whatever force that you're using with these patients, is directed right to the stiff joints. And so what would be the difference between a SIMS cast and the mobilization splints we have? Why don't these work so well? Well, I use mobilization splints all the time in my practice, but for the patients who come into you that really have this kind of ingrained stiffness, I find that these splints just aren't as useful as putting them in a Sims cast, and we think that this is because, first of all, mobilization splints, the passive and active force that's applied to this tissue is short term. It doesn't address the problem of the set abnormal cortical patterns that are set in the CNS. And the scar mobility issue has to be addressed separately. So I think really the positive effect of the SIMS treatment is that all these problems are addressed concurrently within the cast. And so, how do you identify what an appropriate patient for a SIMS would be? You also need to be fairly clear about what an abnormal movement pattern is and what is creating that abnormal pattern, what tissues are not working. And then you have to decide on what cast design you're going to put on that hand, on that stiff hand. So identifying the patients that are appropriate for SIMS. So here's clearly someone who has a very stiff hand. So someone who has painful stiffness, and who has been quite unresponsive to treatment. So sometimes you may just say, well, I'm just going to try, my regular hand therapy tools on this patient, and you may want to do that for, a few treatments and see if that improves. But a lot of times, like I said, they may improve during the therapy session, but then you come back and they haven't made any improvement at all. So that's a good indication that they may be a candidate for this. They may have pitting or fibrotic edema. This is pretty indicative of someone who would be good for SIMS. Obviously, scarring, tissue tightness, adherence of tissues. An altered tenodesis pattern. You'll see in a lot of these patients that they pull from the wrist, that their digital flexion happens from the wrist and not from their digits. So that's a good indication that they might benefit from SIMS. And all of these people have abnormal grasp patterns. So some of them are unable to initiate flexion with the FTP and FDS. Some of them move their wrist and fingers and they flex together. That's that abnormal tenodesis pattern. And some of them are just unable to flex at all from the MCPs. And one thing to be aware of is if their passive wrist extension is limited, then they would be a candidate. Like this woman is a candidate for SIMS, but her passive motion is very limited. I can't get her into extension. I haven't showed you this, with me pulling on her wrist, but she really doesn't have any passive extension. So I would not put a SIMS cast on that patient right away. I would be serial casting that wrist into extension, getting her into, let's say, at least 20 degrees of extension before I even think about putting a SIMS cast on them. Because we know that functional wrist extension must be restored before you can get any normal digital flexion happening. And so now we're going to look at the two most common types of abnormal movement patterns that you would see that would be appropriate for SIMS. So the first person here that I showed you before, this is a person that is a dominant intraossei flexion pattern. That is the abnormal movement pattern they're showing. Dominant intraossei flexion pattern. Now, what does that mean? They're flexing mostly from the MCPs. They're using their intraossei to flex rather than their digital flexors. It's an abnormal pattern of movement. This patient here, let me push it, is moving only from their IPs, and that's considered a dominant extrinsic flexion pattern. And again, he is pulling only from his IPs. He's not moving his MPs at all. And you can see in both these patients that these are both abnormal patterns of motion. It's not normal digital flexion. And these are the two most common types of movement patterns that you'll see. The other thing to note is that both of these patients are activating the flexion with their wrist. So again, every CMMS cast includes the wrist. If you put a cast only on the hand and not including the wrist, that's not considered a CMMS treatment. So let's talk a little bit more about the dominant interossei flexion pattern. Why do patients move only from their MCPs? Well, you have to get really good at doing your tissue tightness testing. And again, it's beyond the scope of this talk here to go through all these, although every one of these is an important thing to understand when you're treating any stiff hand. It doesn't matter if it's a chronic stiffness or beginning stiffness. But generally, people flex from their MCPs when they have, let's say, extrinsic flexor tightness. Their flexors are not gliding. They may have interossei tightness. They may have IP joint tightness. And if they have all these other tightness, then they absolutely for sure have lumbrical tightness. And we know that lumbrical tightness, because it's an active test, you can't really see this clearly until you've kind of resolved all these other problems that are listed above. And then what about the dominant extrinsic flexion pattern? Why do patients move mainly from their eyepiece? Well, again, this comes down to your ability to evaluate what tissue is tight. But generally with these patients, they have extrinsic extensor tightness. So their extensors are not allowing their digits to glide. They may have skin or tissue tightness over the dorsum of the hand or forearm. And they may have joint MP joint tightness, which is what this person here has. So once you've determined which of the two abnormal movement patterns you're working on, so whether it's a dominant interossei flexor pattern or a dominant extrinsic flexor pattern, you have to decide on what cast to use. And there are 6 different cast designs to decide from. Now, you choose this cast design based on the analysis of your abnormal movement pattern. So I'm going to just kind of, again, I'm not going to get into a lot of detail, but I'm going to introduce this topic of how you make this decision. So looking at the dominant interossei flexor pattern, this is when the patient leads digital flexion with the MCPs. So if they're leading the digital flexion with the MCPs, you want to stop the motion at the joints that are moving the easiest. And the joints that are moving the easiest are the MCPs. So you would block the MCPs in extension. And that cast would allow the eyepiece to move freely. So you can see in all of these casts, the MCPs are immobilized in some amount of extension. So 5 different cast positions are used for this dominant interossei flexion pattern. Now, the choice that you make about which of these 5 casts you would use for your particular interossei flexion dominant interossei flexion pattern is based on, again, what tissues are tight. And I'm not going to go into tissue tightness testing, but that is where your evaluation skills are really important in order to figure out what position you should be putting these patients in. So again, this is the dominant interossei flexion pattern. You can see that she's moving easily from her MCPs, and she's also leading digital flexion with her wrist. And so she would be put in one of these 5 different casts where her wrist would be immobilized and her MCs would be immobilized in some amount of extension. What about the dominant extrinsic flexion pattern? In this pattern, the patient leads digital flexions with the IPs. So the PIPs and the DIPs are moving easily, but the MCP doesn't have motion, so they're not moving from the MCP. In this case, you want to position the MCPs in whatever amount of available flexion they have. And so to do this, you can see in this picture, there is a cast that immobilizes the wrist, and the dorsum part of the cast goes up over to the IPs. And this is because that dorsal hood of the cast is holding them in whatever comfortable flexion they have. You're not pushing them into flexion. Whatever they can easily actively flex into, that's the position you hold them in. But they are, the bottom of the cast, the palmar side of the cast is open, and they are free to move their MCPs and their IPs into flexion. Also, a lot of your patients may have extension contractures. They may not, PIP flexion contractures. They may not be able to extend their PIPs fully. And this position of the dorsal hood in flexion allows them to have something to extend the PIPs and IPs against. So that also helps the PIP extension problem. So again, this patient is an example of someone who had dominant extrinsic flexure pattern. You can see that he is unable to flex from his MCPs. He is flexing easily from his IPs. And you can see that when I try to push him, his MCPs, he's kind of tight. He's actually really tight. But what I would do is put this cast that's to the right here, I would put this cast on him, and I would put him in whatever position of easy MCP flexion he has. So I'm not using this as a really strong passive force into flexion. I'm just putting him into whatever a comfortable flexion I can get him in within the cast. And then he, within this cast, will be flexing away from this dorsal hood. So I know that we have to address the big pink elephant in the room, and that's like our whole lives we've been told, what are you doing? Don't cast the MCPs ever in extension. And Judy actually really addresses this really nicely in her chapter in Rehab of the Hand, but I have never had a problem with when I've used the SIMS MCP block SIMS cast. I've never had a problem with the MCPs getting stuck in extension. And in Judy's chapter, she does talk about this. She says that the contoured circumferential compression of the cast around the MCPs, along with the elongation when the patient is moving, the elongation gliding motion of the intrinsic muscles over the MP joint, this overrides the problem of the short-term MP immobilization and extension. So, like I said, clinically, I have not had a problem with these patients having MCP of extension contractures after a SIMS treatment. And I will kind of show you this when I do the case example closer to the end of the talk. So I just wanted to bring your attention to some of the kind of new research that's out. One of my colleagues has done a retrospective study on her results after using SIMS treatment. And she presented this oral presentation at the ASHE Congress in Salt Lake City in October. And her results were great. She found that SIMS led to a significant improvement in range of motion, pain relief, grip and pinch strength, edema reduction, and functional status in patients with hand stiffness. I know she is preparing this for publication, so I really hope this will be out soon. But there really is a paucity of actual SIMS research. Unfortunately, there have been a couple of case studies that have been written up. There's a lot of information out there about this from Judy and from other people, but we really don't have a lot of actual research to show that this is effective and even why it's effective. So I'm hoping that there'll be people who take this on. I know our group is really trying to get some research together to do some publications. But yeah, I hope that if this gets to be a more popular treatment technique, that people will start using it and sharing their results. So I want to kind of go through a case example to help you kind of visualize what the heck I'm talking about. Because again, it's kind of a really difficult concept to present in the short amount of time. So this is that stiff hand that I showed you at the very beginning. She is a lady who had a third finger and fourth finger. On the third finger, she had an MCP fracture. On her fourth finger, she had an MC fracture dislocation. And she was treated in a standard way by an opening reduction internal fixation of her third and fourth MCP. And I just want to show you these two normal movement patterns, the ones that I just spoke about. This is the movement pattern that's extrinsic flexor movement pattern. And this pattern that's interossei dominant flexor pattern. And then looking at her pattern, it's kind of like neither one. It's kind of a combination of both. And you may really get patients who come in like this. So again, how you go about figuring out what to do with these patients. So sometimes the movement is not always perfectly clear. So just giving you a little bit of background about her, this patient in this particular, let me just play this. In this video, she's 6 weeks post-surgery. So she already had, by the time she came to my clinic, she had already had 5 weeks of general therapy at another facility. And when she came in, I immediately wanted to do SIMS with her, of course, because that's just what obviously to me that what we had to do. But I couldn't convince her to do this. So I did 3 hand therapy sessions with her, and she did better. She did have, better motion. But now you can see that she kind of does have a little bit more of a dominant, I don't know, IP motion. It's still kind of not clear what pattern she has to me there. And so because sometimes the pattern is not clear, how do you make the decision about what cast to put on first? And when I make this decision, I remember always what is normal digital motion, the pattern of normal digital motion. When you digitally flex your fingers, you first start digital flexion at the DIPs. So first DIPs, then the IPs, then the MCPs, and then those intrinsic and lumbricals pull you into a full fist. So you really have to understand what normal digital motion is to be able to decide, well, if a patient comes into me and they don't really have one of those clear movement patterns, what cast am I going to put on them first? So I'm going to talk you through this. So the first cast that I put on her, this is her motion. So the first cast that I put on her was the MCP block SIMS. That's this one. Play the video. So within this cast, I immobilized her MCPs, and I immobilized her MCPs in a little bit, as much extension as I could get them into, because I recognized right away with my evaluation that I had done with her that her intrinsics were really tight. So I wanted to put her in some amount of interossei lengthening. So when I bring her MCPs into whatever amount of extension she can get into, and I have her flex her IPs, I'm lengthening those interossei and, of course, the lumbricals. So I decided to put this cast on her first. This was the first cast I put on her. And when I put it on her, I had her move towards these dots. So I instructed her to bend her digits towards the dots. And again, when the patients do this, they really want to fight the cast. And so what I told her to do was push against the back of the cast and flex towards those dots. So you're really getting a full hook fist as opposed to them kind of fighting the cast and trying to bend from their MCPs. So I really had her push against the back of the cast and flex those digits down towards the dots. Besides this, of course, we did a lot of other things with her. So this is her 1 week later. She had the cast on and she came, let me just push this. She came in and her motion was improving. I added this kind of kinesio tape here because it was the cast was kind of digging into her. So I did some adjustments to her cast. I also added this thermoplastic insert, which more directed the force again towards her DIPs, because I really felt like she was pushing too much against this cast. She was still initiating the movement from her MCPs and not from her DIPs. I also added this part of this thermoplastic insert to the back of the cast, to the dorsum of the cast, so that she could push against something to help straighten the PIPs that had a very slight flexion contraction. I also had her, of course, do all sorts of exercises within this cast. So again, I really want to stress that they are not sitting wearing the cast. They are moving constantly within the cast. I'm having them do exercises. I'm having them do carrying objects. I'm having them try to use their hand functionally. I'm really trying to get them to move the hand within that cast. And the reason for that is that you have to train the brain. You really have to get the brain used to moving in that more normal motion. And so when after she came back after 2 weeks, so I saw her for the first week, I made those changes, and then she came back in the second week. I was pretty happy with the motion she had. She was doing much better. And here in these two pictures, you can see this was her IP motion at the beginning, and this was after the second week. So she had obviously made some pretty good gains. And so I knew that her bigger problem was her MP flexion. So I only kept her in this cast for 2 weeks. And then I took the cast off, and this is her motion after I took the cast off. So here you could see that right now, if you were looking at what movement pattern she has a dominant extrinsic flexor pattern, right? She's flexing from her IPs mostly. And I also wanted to show you that when I took the cast off, oh, sorry, let me just go back to this. When I took the cast off, look at how soft that tissue is. Look how much more mobile. When I put the cast on, there was no motion in that tissue at all. And the volume of the tissue in the hand was much smaller, and it was much softer in the palm as well, where you get that really brawny fibrotic edema that happens in the palm. And so I took the cast off, and then I bivalved the cast. So don't forget, we have another whole process. It's called the bivalving process of the SIMS treatment process, right? You took the cast off, but you have to bivalve it. So you cut open one side of it, and I also cut this side, lower part of this open, and it becomes a splint. It becomes something that you can take on and take off. And I add these straps that are cinch straps to make sure that I get a nice conforming tightness when they put the cast back on. So after she wore this block splints for 2 weeks, I bivalved the cast, and I had her wear this cast continuously except for hygiene, and she took it off for wrist range of motion. So I had her wear this probably for 80 to 90% of the day. She didn't sleep with it because it wasn't necessary to sleep with this cast. So she wore this bivalved MCP block SIMS cast for 10 days. So I was having her wear the bivalve cast for 10 days. And then I realized that it was time to start working on the next movement pattern that she lacked. And so I put on the next SIMS cast. So this is her motion right before I put on the next cast. I just took off the first SIMS cast. So the SIMS cast 1, the MCP block SIMS, the goals were achieved. So my next SIMS had to address the next stage of digital flexion, which you can see from here is first you have IP flexion, which I just restored, and now you have MCP flexion. So the next cast I put on her was this cast. And this is the cast that holds the MCPs in whatever amount of flexion you can get them into. And there's this dorsal hood that's holding the MCPs in that amount of flexion. And she is actively flexing the MCPs away from the hood. So I'm getting her to pull from her MCPs mainly. I'll play it again. I'm getting her to pull mainly from the MCPs. She can move her IPs, of course, but I'm trying to get her to move right initially only from her MCPs. So the cast that I've put on her is this cast, the one that I showed you previously, where there is a dorsal hood. It's holding the MCPs in whatever amount of MCP flexion they can get into, and they are allowed to actively flex their MCPs and their IPs. And so after 3 days, she came back in. So this is after 3 days. She's already improving a lot. So in a minute, I'll take this out. You'll see that I put this thermoplastic insert in because I'm pretty lazy and I didn't want to recast her. And there's no need to recast her because she made such big improvements. I added this thermoplastic insert to increase the amount of MCP flexion in this cast. So right now you can see that she's moving a lot. This was day 1 where she's moving, and in 3 days she already had quite a bit more MCP flexion. You can see that there's a pretty big difference. And then I add that MCP thermoplastic insert to just increase the amount of MCP flexion that she's doing within the cast. She wore the MCP thermoplastic insert for sleep. So she wore this cast during sleep, and so I was able to push the MCPs passively during sleep time into more MCP flexion. And during the day, she wore the thermoplastic insert 50% of the day. Otherwise, she was moving just like this in this position. Then by week 2, so she came back again 10 days later, and by week 2, you can see that there is the first thermoplastic insert, and there is the second thermoplastic insert. So again, she was making really big gains in her MCP motion. And so again, that's the first thermoplastic insert. I was having her bend her fingers. Right now, I'm working at even getting her into doing a straight fist. So not working only on the MCP flexion. I'm working on MCP and PIP flexion. I'm having her move towards that line. And then she can also take it out and move, more freely and try to do a little bit more flexion. And again, I'm adding therapy and having her do all sorts of different exercises, functional tasks with this. And then this was, again, day 10 after she had been wearing the first a thermoplastic insert. That was day 10. And again, just adding putty exercises is really helpful. And so she wore this cast for 3 weeks. So this is her motion right before I bivalve this cast. So don't forget, you haven't achieved results. Just because you get great motion within the cast doesn't mean you're done. And your patient really has to understand this too, because they are dying to get this cast off their hand. So I took the cast off, and this was her motion after I took the second CMMS cast off. So the MCP flexion cast. So pretty good, lots of improvement, but you can see that she doesn't really have full motion yet. So again, you're not done with therapy. Just because you've taken your casts off doesn't mean you're done. So I bivalved the MCP flexion cast. Unfortunately, I don't have a picture of the bivalve cast. I forgot to take a picture of it. And she wore this bivalve CMMS, the second MCP flexion cast was bivalve, and she wore it again 90% of the time. She wore it for sleep as well, because in this cast, I wanted to use that time when she was sleeping to keep the MCPs passively into flexion. Her home exercise program included when she would take the cast off, let's say 4 times a day to do her exercises, included to put on the first cast and do her MCP block resisted exercises. And she also did her rest and form and other functional exercises. So she used the time 4 times a day when she was out of this cast that was bivalve to do work with the first SIMS cast and do her other exercises. And your weaning period, during the weaning period, your therapy is continuing. So your normal hand therapy evaluation and treatment is continued. So again, this is her motion. I don't know exactly when this is after. I think she probably had worn her bivalve cast now for another couple of weeks. Pretty good. But from my testing of her motion, when I did her tissue length testing evaluation, there really was significant evidence of interossei and again, lumbrical tightness. And so I added this treatment tool to her, which this is not SIMS because I have a cast for her that I'm immobilizing the MCPs with a cast, but I'm having her trying to get her MCPs, trying to get her IPs into this thermoplastic insert. So it's really working on her, really pulling into that hook fist in order to get the lengthening of the intrinsics. So we did that for quite a while as well. And then, of course, once you're weaning them, of course, during the whole time, you're working on their strengthening and their other motions. So again, her motion was improving the whole time. She even got better at doing this exercise, which she got really pretty good at. And of course, I was working on strengthening with her. So she had a really extensive home program. And suffice to say that you absolutely have to have this patient buy into this treatment. It really is involved. This is her initial motion, and this is her final motion. She was really happy, of course, with her motion. I was really happy with her motion. But this doesn't happen without the patient being fully involved in this treatment. So I know that we're getting close to missing out on questions, so I'm really not going to discuss these two things that I was going to discuss. I want to skip over to different types of learning opportunities. There is a free SIMS discussion group. You are welcome to join, although for anyone on this side of the world, it's in the middle of the night. So I get up in the middle of the night, every second Tuesday of the month, and I get up and run this group with my other colleagues. So of course, anyone who wants to get up in the middle of the night, you're welcome to join. You can just click on this link. We also have a SIMS LinkedIn page that we monitor, so that we also share cases and answer questions on this. And of course, we have these courses that are run by ASHT in the States, but for patients who are outside of the States and who want this course, I can do a 1-day or 2-day advanced course. We also do different types of, at different congresses, we do these kind of workshops. And I'm going to stop sharing, and maybe if anyone has questions, I can answer the questions for you.
Thank you, Hannah. That was amazing. I feel enlightened. Yeah, thank you for such an excellent presentation, and I really appreciated the resources at the end. We did have some really excellent questions in the chat, which I'm going to try and pick out a few key ones. One of the first ones was, do patients have pain? And do you push past the pain when using SIMS?
No. So actually, the patients that I've used SIMS for, I have put on a cast on patients who have pain. And honestly, if it is a truly stiff hand, that compression from the cast and the fact that they are moving within the cast and they're lengthening these tissues that are so tight, really their pain is decreased. So generally, I would say that in normal cases of a stiff hand, even if they have pain, I'm putting a cast on them. Of course, you monitor them. Like any other treatment that you do, you really need to monitor them carefully. If you're worried about them, for example, I have put a cast on a patient and had them come back the next day. Because generally I'll put a cast on them and I'll have them come back in a few days. I won't have them come back the next day. But if I'm worried about them, I'll have them come back the next day, or I'll have them sit in my clinic and do the exercises longer than I would normally keep the patient in my clinic, and just have them, work through, see how they're comfortable, see if they are comfortable with the cast. And of course, if they're not, I would remove it. I had a colleague who put a cast on the patient, and that patient had that feeling of just they needed to get the cast off. They were really stressed about the cast, and she took it right off them. If they're if it's that type of situation, you really have to monitor how the patient is with the cast. So.
Well, thanks. That's helpful. Um, Matthew asked quite a helpful question for our context, but I think you may have answered it right at the end of your presentation. He said, in a rural context, often we can't get patients back every 2 weeks or every week. And at the end of your presentation, you spoke about, patients really need to buy in. So in the situation where you've got patients who can only really come for therapy once a month due to contextual factors and financial resources and that kind of thing, is this something that you even give a go with it or not?
So I have the same issue in Bulgaria. I have a lot of patients who cannot come. They may see me once every 2 weeks or once a month. They can't come because they come from all over Bulgaria. But what I would do in that case, I have had this problem, and what I ask them to do is if they can, to stay at least for a good part of the day. They come in early, I put the cast on them, I have them do the exercises, and they're in the area making sure that everything is okay before they leave. If they could stay overnight, I ask them if they can do that, if it's at all possible. If it's not, basically what I tell them is if you have any problem with this cast, you need to go to your emergency room and get the cast taken off. I mean, that's the only thing I can tell them. But I have not had that be a problem. I have put casts on patients who live, 5 hours away or whatever, and they can't get to me. I'll leave the cast on. They send me videos of their motion. The problem is that for the cast to be effective, you need to make those corrections that I was showing you. Like I never just put a cast on and have them go away. So unfortunately, sure, you can put a cast on them and have them do the same exercise through that whole, whatever period of time it is that you're not seeing them, but their motion is going to improve. And for the cast to be really effective, it really is helpful to be able to put in those inserts that they have. So, maybe the first time you put the cast on, you can have them come back, if at all possible, within the first 10 days after putting the cast on, so you can make those initial corrections. If you put a cast on a hand that's really swollen, that cast is going to be big because that swelling is going to go down, and the cast is going to again not do the job that it's meant to do. So use your clinical judgment. It is all I can say. It's not always an easy option if they live far away. But on the other hand, once you've got that cast set and you're pretty happy with it, then you can leave them for 2 weeks or 3 weeks. It's not a problem, and they're doing their exercises within that cast. So
Yeah, so I think that's helpful. And Matthew, just my 2 cents, if you are in South Africa, for some of these patients, we did apply for temporary disability grants as an option. And if you can get them just a temporary grant to access services regularly for a few months. We did that a couple of times when you do have a patient who's really committed, but I think that buy-in is also the other part of the clinical
it's the
reasoning.
buy-in, yeah. And I get them to buy in. I show them videos of what I've done with patients, other patients. Of course, I get the patients okay for this, but I show them why I'm doing it. I explain really well why I'm doing it. Well, why I think this is going to be helpful for them. So really, it's just education. You really have to talk to them and make sure they're okay with it.
Yeah. There were a few questions just about the bivalve cast, which I'm going to throw together, and then you can give them a bash. Um, um, so one of them was, can you start with the bivalve cast at the beginning? Um, because I think the concern was just around someone starting with a cast that can't be removed. And then the other question around it was, um, why do you take it off when sleeping? And if you take it off when sleeping, do you have a night splint? Is there a different splint you use? And what is kind of the clinical reasoning around sleeping with the first cast that can't be removed, and then not sleeping with the second cast that
Yeah,
with
yeah,
the
good
bivalve
question.
cast? So
Yes,
just a few around those, if you can
bivalving.
give that a bash. Yeah.
So, first of all, bivalving. The question about whether you could bivalve the cuts right away. Sometimes, in order to get them to buy into this, I say to them, put the cast on for, let's say, a day. And if you really don't like it, I'll bivalve it the next day or, whatever it is that we agree on. I try to get them to buy into it. And if you think that they're not good, they're really hemming and hawing because, like, seriously, no one wants to put a cast on their hand. So if you say to them, listen, I will put this cast on. You can't bivalve a wet cast, first of all. So for sure they have to wear it for like a day. Let's say, for sure a day they have to wear it, because when I use the saw to take off the cast, it can't be wet. It's not going to bivalve properly. So they have to wear the cast for sure for one day. So if they want that cast bivalve, then they come back the next day and I'll bivalve it for them, because for me, from my mind, it's better to get them on some type of, as much as I can, to be doing that normal movement pattern, even if initially they aren't going to be wearing it full time. The result will not be what you want, but it may be a step towards getting the final result. So if you have to get buy-in to this technique, then that is an option. Of course, you could bivalve right away. The next question was, why would you wear a bivalve cast sometimes at night and sometimes not? So in that particular situation, this case example, her motion, when I was trying to get her to do her IP motion, right? The only use for this cast is active motion. If she's in the cast, I've bivalved it already, right? So I'm having her in the day wear this cast where she's moving constantly in this position. This is the cast and she's moving like this. At nighttime, she's not moving. There is no benefit to this cast. I'm not stretching anything. There's nothing that I'm doing that's requiring her to passively improve for that particular movement pattern. So I tell her you can take the cast off for nighttime. In the second cast, though, I was using those inserts that I put in to passively push, keep her MCPs in a flex position. In that case, I do want her to wear that bivalve cast at night because I want her to sleep in an MCP flex position. So, and then your question also was whether I would at night put another splint on them. Of course, if I had a patient who I was working on IP flexion, but then I took the cast off and they also had extrinsic extensor tightness, I would put them in a nighttime extrinsic flexor stretcher, right? So of course you can do, when you've bivalved the cast, at nighttime you can use other casts, other splints to work on other problems that you have. Absolutely. So I don't know if that's clear about the difference, why I had the person sleep with that MCP flexion cast. It is because her problem, she passively could not, she had passive limitation of the MCP. So I wanted to use that sleep time to keep that corrective force on the MCPs into flexion.
Thanks, Johanna. I think that's probably how much we've got time for in terms of questions. Yeah, and if you guys still have outstanding questions, you're welcome to email, and we can see if we can get those answered for you in a different platform. But let me just finish up here. Um, So thank you for joining us. It was cool to see about 400 people in this Zoom. You will receive a link to the recording at the end of the week. I saw that question pop into the chat. And if you are a little bit more patient, we do a little bit of editing and pop the webinar on YouTube. So keep an eye on our social media channels when that becomes available a little bit later on. Our next webinar is going to be on the 7th of April. We are looking at dealing with the drop. With Tammy Williams, we'll be addressing hand therapy for radial nerve injuries. I hope you'll join us. Again, keep an eye out for those sign-up links on all the very different platforms. This is where you can find us. The mailing list is the easiest because it will come into your emails every month with a little bit of news from us and the next webinar registration link. But you can also follow us on Instagram. We're over 800 followers. If you help us share, we can get to 1,000 sometime soon. Or Facebook, and then obviously our YouTube channel that you can take a look at all of our previous webinars. We're building up quite a nice repository. And that is the end for this evening. Thank you, everybody. Apologies for those whose questions we didn't quite get to. And
And
we
if
didn't
anyone has
cover.
questions, my email is in the actual presentation, which I think you guys are going to send out. So
Yeah, thank you so much, Johanna. We really appreciate your openness to continue the conversation. As you said, just a just a taster. I don't
just
think
the
we would
taste.
have been
Yeah,
able to cover it all in 1 hour. So
only a pleasure. Thank you so much.
cool. Have a good evening.
Bye, everyone.
Bye.